Thank you.
So, good afternoon, ladies and gentlemen. Radiation chorioretinopathy is a relatively predictable complication of eye radiation and is basically composed by two different ways. The macular edema, the edematous changes of the macula, and the ischemia of the macula. These two components at the end of the process cause retinal and choroidal atrophy. Probably there are new evidence about the role of neuroinflammation in this disease, but this is another history. What I want to speak today is the choroidal role of involvement in this disease, because it's not fully understood. Because the choroid is the hidden actor, not only because not many of us use ICG angiography to study the disease, but also because it's not something we want to look. But if you come back in the 90s, a person that used ICG angiography for this disease clearly described choriocapillary ischemia and hypoperfusion in irradiated eye. But now we are in another era. The era is the era of OCT angiography. And there is some evidence about the changes in vascularization, mainly the ischemia of the choriocapillary detected using OCT or OCT angiography. So the aim of our study was to describe the progressive vascular changes secondary to ocular irradiation for uveal melanoma using both OCT and OCT angiography. So we have enrolled 60 eyes affected by primary uveal melanoma and 40 eyes as a control. Each patient underwent full ophthalmologic examination and underwent brachytherapy with iodine 125. Patients were followed more than 12 months, and each patient underwent multimodal imaging during the follow-up every 3 months. That's composed by OCT and OCT angiography. What we have looked at, we have looked at the choroidal vascular index. You take a single OCT scan of the fovea, you binarize the image, and then you select 1,050 microns of the choroid under the fovea. In this lab, you have to select the luminal area, that is the black area, and the stromal area, that is the white area. And doing that, you can obtain the choroidal vascular index, that is the black total pixel ratio. We have also used OCT angiography. You can see here the vessel density. This is the calculation after binarization of the image of the choriocapillary of the white total pixel ratio. And also we have looked in detail at what are called signal void spots that are areas of no perfusion. These areas were quantified by an observer. So what we have found is this. For example, the signal void spot increased in a percentile from 3 months to 12 months from 67 to 88%, and also the vessel density decreased from 81% at 3 months to 67% at 12 months. And this is a signal of early and progressive microvascular abnormalities in the choriocapillary. What was strange for me is that all these changes, also the rarefaction and the dilatation of the choroidal vessels that increase during time, precede the retinal changes. That means that it is absolutely rare to see changes in the retinal capillary when you found these findings in the choroidal area. And also the choroidal vascular index decreased during the follow-up, as you can see here, 12 months. So if we look to the retina and the choroid, and if you think to the physics of the irradiation, we know that the damage caused by irradiation are strictly related to the oxygenation of the tissue. And if we look in the retina and in the choriocapillary, we know that choriocapillary is the tissue with a higher oxygen tension. That's probably is the reason why we have found much more damage in the choriocapillary compared in the retina. So in conclusion, using OCT and OCT angiography, we can detect early microvascular abnormalities in the choriocapillary level after brachytherapy, but probably also after other type of irradiation. The choroidal-like flow, that means choroidal or choriocapillary oxygenation, make this tissue probably more sensitive to irradiation. And what is strange is that choroidal changes precede the retinal ones. That means that looking at the choriocapillary, probably in a near future we can precede and prevent what is the changes in the retina. Thank you.
Thank you, Raffaele. Fantastic work. Regarding radiation retinopathy itself, sometimes we think that a little bit dead is worse than dead. For instance, venous occlusion has more problems than arterial occlusions. In your work, can you see a correlation with that? That if the choroid survives better, you have more problems actually?
We have not looked exactly to these parameters, but we are now starting to do that because it was absolutely interesting also for the circulation of the big choroidal vessels that are sometimes involved not only by the tumor, by the surgical procedures, and so on. What we have focused to is in a patient without the macular involvement by the tumor and the brachytherapy, direct irradiation, if the changes is first in the choroid or first in the retina. And this for us is absolutely important because sometimes we forgot that the choroids have a role in this disease. Also thinking about the diabetic retinopathy, then we know that some drugs does not work in the choroidopathy, in diabetic choroidopathy. And probably we have to change our vision that the retina is not the only actor in the disease, but also the choroid.
Fantastic. Thank you very much. Can we ask Dr. Nack for the next presentation? If in the meantime, Dr. Cunha and Dr. Korobelnik are in the auditorium, if they just make yourself known to us, that we can go on. Dr. Nack, please. Thank you.